Welcome to the deep dive. Today we're tackling a subject that's absolutely foundational for anyone entering the world of nursing: how medications interact with and move through the body. We're going to be pulling apart the core principles nurses rely on to administer drugs safely and, well, effectively.
That's right. For those of you who are current or future nurses, this isn't just about memorizing facts for an exam, Understanding these concepts is the very basis for predicting how medication will affect your patients, being alert for potential adverse reactions, and ultimately providing the best possible care.
And to really get into the nuts and bolts of this, we've got some great material focused on nursing pharmacology as our guide. Our goal in this deep dive is to extract the crucial knowledge about how drugs work in the body and what can influence their effects, presented in a way that's, well, clear, engaging, and really sticks with you. Okay, let's unpack this, starting with pharmacodynamics, essentially. What the drug does to the body.
So, pharmacodynamics is all about the impact a drug has on the body. The material we're looking at outlines 4 primary ways drugs typically exert their effects. First, they can act as replacements for missing substances, which is pretty straightforward when you think about conditions caused by a deficiency.
Okay.
Second, they can boost or stimulate specific cellular activities. Conversely, they can also, reduce or slow down those same activities. And finally, there's the category of drugs that interfere with foreign invaders, like bacteria or cancer cells. These are our chemotherapeutic agents.
Those are the main categories, but how do these drugs actually interact with our cells? The material talks a lot about receptor sites. Can you explain what those are all about?
Okay, think of receptor sites as very specific docking stations on the surface of our cells. These sites are designed to bind with particular chemicals in the body. A common analogy is the lock and key. A specific drug molecule, the key, will fit precisely into a specific receptor site, the lock. When this binding occurs, it triggers a chain of events, leading to a response within the cell.
So once the drug key engages with the receptor lock, what kind of responses can we expect?
Well, the material details a few different types of interactions. First, we have agonists. These are drugs that bind to a receptor site and essentially mimic the action of a naturally occurring chemical in the body. A classic example is insulin.
Right, insulin.
It binds to insulin receptors on cells, just like the insulin our own bodies produce, which then helps glucose enter the cells. It's essentially stepping in and doing the same job.
That makes perfect sense. So agonists are the helpers, imitating what the body already does. Now, what about antagonists? They sound like they have the opposite effect.
Exactly. Antagonists are drugs that also bind to receptor sites, but instead of triggering a response, they block the normal stimulation of that site. The material mentions competitive antagonists like Curare.
Oh, Curare, okay.
Curare binds to acetylcholine receptors, which are vital for muscle contraction. By occupying those receptor sites, it prevents acetylcholine from binding and doing its job, resulting in paralysis. It's a direct competition for the same spot, you see.
And then there are non-competitive antagonists. How do they work differently?
Non-competitive antagonists also prevent the action of a natural chemical, but they do it by binding to a different site on the cell membrane. When they bind to this alternative site, they cause a change in the shape of the main receptor site. So the natural chemical either can't bind at all, or if it does bind, it can't produce the expected effect. Think of it like gumming up the works in a nearby mechanism so the keyhole itself is no longer functional.
That's a really clear way to picture it. The material also mentions partial agonists. That sounds like they have a foot in both camps.
Yeah, that's a good way to think about it. Partial agonists can exhibit both agonist and antagonist effects, but it depends on the specific receptor site they're interacting with. Nalbuphine, an opioid pain reliever mentioned, is a good example.
Nalbuphine, okay.
At one type of opioid receptor, the kappa receptor, it acts as an agonist, providing pain relief. But at another type, the mu receptor, it acts as an antagonist, which can help reduce the risk of respiratory depression often associated with other opioids. It's kind of a delicate balancing act at the cellular level.
It's fascinating how a single drug can have such varied effects depending on where it acts. Now, moving beyond receptor sites, drugs can also interact with enzymes, right?
Yes, absolutely. Enzymes are essential proteins in our bodies that speed up all sorts of chemical reactions. Some drugs work by interfering with these enzyme systems. The material gives the example of acetazolamide, a diuretic that inhibits an enzyme called carbonic anhydrase.
Carbonic anhydrase.
Right. By blocking this enzyme in the kidneys and eyes, the drug alters the balance of fluids and electrolytes, leading to its diuretic effect. It's like putting a roadblock in a specific metabolic pathway.
So it's like throwing a wrench in the gears of a specific metabolic pathway. Now, this brings us to the idea of selective toxicity, which sounds like the ideal scenario in drug development.
It truly is. Selective toxicity refers to the ability of a drug, especially something like an antibiotic or an antiviral, to target systems that are unique to the foreign cells, like bacteria or viruses, without causing significant harm to healthy human cells. Penicillin is a classic example provided.
Penicillin.
It targets an enzyme system that bacteria need to build their cell walls. This leads to bacterial death, but leaves our own cells unharmed because, well, we don't have that same enzyme system.
That's brilliant. A true biological guided missile. But the material also points out that this level of selectivity isn't always achievable, particularly with cancer drugs.
Unfortunately, that's often the case. Many cancer chemotherapeutic agents aren't as selective and can also damage normal human cells, especially those that are rapidly dividing. Think bone marrow, cells lining the GI tract, hair follicles.
Right, the common side effects.
Exactly. This is why we see many of the challenging side effects associated with cancer treatment. The therapeutic goal often becomes finding a dose that is toxic enough to kill the cancer cells, but causes the least amount of collateral damage to the patient's healthy tissues. It's a tough balance.
Okay, that's a solid foundation in pharmacodynamics, what the drug does to the body. Now let's flip the coin and delve into pharmacokinetics, what the body does to the drug. The material outlines 4 key processes here.
Yes, pharmacokinetics describes the journey of a medication through the body. It encompasses 4 main stages: absorption, distribution, biotransformation, also known as metabolism, and excretion. These processes are absolutely critical because they determine how quickly a drug starts to work, its onset of action, when it reaches its maximum concentration and effect, its peak, and how long its effects will last, the duration of action.
Let's start with absorption. What exactly is happening during this phase?
Absorption is the process by which a drug moves from its site of administration, whether it's swallowed, injected, or applied to the skin, into the circulating fluids of the body, primarily the bloodstream. The material highlights that drugs can be absorbed from various locations: the GI tract, oral or rectal, mucous membranes, like under the tongue or in the nose, the skin, topical, the lungs inhaled, and muscle or subcutaneous tissues injected.
And the route we choose to administer a drug has a significant impact on how quickly and how much of it gets absorbed, right?
Absolutely. Generally speaking, oral medications tend to be absorbed more slowly compared to those given parenterally, meaning by injection. If a drug is administered intravenously, 4V,
Right.
it goes directly into the bloodstream, so absorption is immediate and considered 100% complete. Intramuscular, or IM injections, are usually absorbed more rapidly than subcutaneous injections because muscle tissue has a richer blood supply. Think of it like a highway versus a back road in terms of getting the drug into circulation.
What about oral administration? It's the most common route, but it sounds like the drug has to overcome several hurdles.
It does indeed. Oral administration is convenient, less invasive, but the drug encounters several barriers. The acidic environment of the stomach can actually break down some drugs before they even get absorbed, and the presence of food in the stomach can also significantly affect absorption, sometimes increasing it, sometimes decreasing it. For an oral drug to be absorbed, it also has to cross the layer of cells lining the GI tract. The material emphasizes the importance of knowing whether an oral medication is best taken on an empty stomach or with food to optimize its absorption. It really matters.
So it's not just a matter of swallowing a pill and hoping for the best. There are a lot of factors at play. What about the actual mechanisms by which drugs are absorbed? The material mentions a few.
Yes, the primary mechanism for drug absorption is passive diffusion. This is where a drug molecule moves across a cell membrane from an area of higher concentration to an area of lower concentration. This process doesn't require the cell to expend any energy.
Okay, passive diffusion.
Right. It works best for small drug molecules that can dissolve in both water and lipids and don't carry an electrical charge.
And then there's active transport.
Active transport is different because it requires the cell to use energy to move a drug molecule across its membrane. This mechanism can move larger molecules and can even transport them against a concentration gradient, so from lower concentration to higher concentration. While it's not the main way most drugs are absorbed across the GI tract, it plays a crucial role in other processes, like absorbing certain nutrients and excreting drugs in the kidneys.
And the last mechanism mentioned is filtration.
Filtration involves drugs moving through tiny pores in the cell membrane. This movement can occur due to a concentration gradient or because of pressure differences, like the pressure exerted by blood. Filtration is another process the body uses extensively in the kidneys for drug excretion.
Okay, that covers absorption, how the drug gets into the bloodstream. Now, once it's there, it needs to get to where it needs to exert its effects. That's distribution, right?
Exactly. Distribution is the movement of a drug from the bloodstream to the various tissues and organs in the body. Several factors influence this process, including the drug's ability to dissolve in lipids, its lipid solubility, whether it's ionized, carrying an electrical charge, and the amount of blood flow to the target tissue. We call that tissue perfusion.
Tissue perfusion, right.
So, for example, in a patient with poor circulation due to, say, diabetes, a drug might not distribute as effectively to an infected foot. The blood flow just isn't getting it there efficiently.
The material also highlights the importance of protein binding. Can you explain why that's significant?
Ah, yes. Many drugs bind to proteins in the blood, mainly albumin, to be transported throughout the body. However, and this is key, it's only the unbound portion of the drug, the molecules not attached to protein, that are actually able to leave the bloodstream and exert their pharmacological effects on tissues.
So only the free drug works.
That's right. If a drug is highly protein-bound, it means that a smaller percentage of the administered dose is readily available to reach its target sites. Plus, some drugs can compete with each other for these protein-binding sites.
Oh, competition?
Yes. If one drug displaces another from the protein, it can lead to a sudden increase in the level of the displaced, now free, drug in the bloodstream, potentially causing toxicity. It's like two people trying to share a limited number of seats on a bus. If one person gets pushed off, they're suddenly free to roam elsewhere, potentially causing problems.
That makes sense. It's like having limited seats on a bus, and some passengers are more assertive about getting a spot. What about the blood-brain barrier? It always sounds like a formidable obstacle.
It is a very selective protective mechanism. It prevents many substances, including a significant number of drugs, from entering the central nervous system, the CNS. The material points out that drugs that are highly lipid-soluble are more likely to cross the blood-brain barrier and reach the brain.
Lipid-soluble drugs get through easier.
Correct. This has important implications for treating infections or other conditions in the brain because many antibiotics, for example, are not very lipid-soluble and therefore have difficulty crossing this barrier. Effective treatment might only be possible if the infection is severe enough to actually compromise the integrity of the blood-brain barrier itself, making it sort of leaky.
So it's a double-edged sword. It protects the brain, but can also make it difficult to get necessary medications in. The material also briefly mentions the placenta and breast milk.
Yes, and these are critical considerations. Many drugs can cross the placenta and potentially affect a developing fetus. This is why it's absolutely crucial to carefully weigh the risks and benefits of any medication prescribed during pregnancy. Similarly, many drugs can pass into breast milk and could potentially affect a nursing infant. Nurses always need to verify if a drug can be transferred through breast milk before administering it to a lactating patient. Always check.
Okay, so we've covered absorption and distribution. Next up is biotransformation, or metabolism. What is the body doing to the drug during this process?
Biotransformation is the process where the body chemically alters drugs. The liver is the primary site for this, although it can also happen in the GI tract, the kidneys, even the bloodstream. Think of the liver as the body's main processing plant for detoxifying foreign substances, including medications, and preparing them for elimination.
So it breaks them down?
Often, yes. Biotransformation frequently makes drugs less active and more water-soluble, which makes them easier for the kidneys to excrete. However, the material also notes that some drugs are actually activated by biotransformation. These are called prodrugs. And some are broken down into active metabolites, meaning the breakdown products themselves still have pharmacological effects. It's not always just about inactivation.
The material mentions the first pass effect. That sounds like a really important concept for orally administered medications.
It is indeed very important. When a drug is taken orally and absorbed from the small intestine, it travels directly to the liver via the portal vein before it enters the general systemic circulation. The liver then immediately begins to metabolize a significant portion of the drug.
Right away.
Right away. This first pass through the liver can inactivate a large percentage of the drug before it ever reaches its intended target tissues elsewhere in the body. This is why oral doses of some drugs may need to be much higher than doses given by injection, which bypass this initial liver metabolism entirely.
And the hepatic, microsomal system, and cytochrome P450 enzymes are the key players in this liver metabolism, right?
Absolutely. The hepatic microsomal system is a network of enzymes within liver cells responsible for the biotransformation of a vast array of chemicals, including many medications. The cytochrome P450, or CYP450 system, is a large family of these enzymes that play a central role in what's known as phase I biotransformation reactions.
Phase 1.
Yes, these reactions typically involve oxidation, reduction, or hydrolysis of the drug molecule. Phase 2 reactions then often involve conjugation, where the drug molecule is attached to another molecule, making it more water-soluble and even easier to excrete. Think of the CYP450 system as a team of specialized workers in the liver, each with slightly different tasks in processing drugs.
The material also talks about enzyme induction and inhibition. How do these processes affect drug metabolism?
Enzyme induction is when the presence of one drug or chemical causes an increase in the activity of a liver enzyme system. This can lead to faster metabolism, not only of the inducing drug itself, but also of other drugs metabolized by the same enzymes, potentially reducing their effectiveness.
So it speeds things up.
Right. And enzyme inhibition is the opposite. A drug can block the activity of an enzyme system. This can slow down the metabolism of other drugs that rely on that enzyme, leading to increased drug levels in the body and a higher risk of toxicity. These types of interactions are a major reason why certain drug combinations can be dangerous and why a thorough medication history is so important for nurses to obtain.
Okay, we followed the drug through absorption, distribution, and biotransformation. The final pharmacokinetic process is excretion, getting the drug out of the body.
Yes, excretion is the removal of drugs and their breakdown products, or metabolites, from the body. While routes like the skin, through sweat, the lungs, exhalation, bile, which ends up in feces, and the feces themselves are involved, the kidneys are the primary organs responsible for drug excretion.
The kidneys are key.
Absolutely. The material mentions monitoring blood urea nitrogen, BUN, and creatinine levels as important indicators of kidney function. This is crucial for proper drug elimination. If the kidneys aren't working efficiently, drugs can build up in the body to toxic levels.
And how do the kidneys actually get rid of these substances?
The material describes glomerular filtration, where water and small water-soluble substances, including many drugs, are filtered from the blood into the renal tubules. There are also active transport systems in the kidney tubules that can actively secrete certain drugs from the blood into the urine.
Active secretion, too.
Yes. And interestingly, the acidity of the urine can sometimes influence the rate at which certain drugs are excreted through these active transport mechanisms. So, a patient's kidney function and even their urine pH can be important considerations when administering medications.
So healthy kidneys are essential for eliminating drugs properly and preventing them from accumulating to harmful levels. Now let's move on to some important concepts related to drug concentration in the body. Critical concentration and therapeutic index.
The critical concentration is the minimum concentration of a drug in the body's plasma or tissues that is required to produce a therapeutic effect, the desired beneficial outcome. For a drug to be effective, it needs to reach and maintain this concentration at its site of action. Below that, it likely won't work.
And the therapeutic index helps us understand the drug's safety margin, right?
Exactly. The therapeutic index is a ratio comparing the blood concentration of a drug at which it becomes toxic to the concentration at which it is effective. A drug with a high therapeutic index has a wide safety margin.
So more wiggle room.
Right. There's a large difference between the effective dose and the toxic dose. These drugs generally don't need as much intensive monitoring of drug levels. However, drugs with a low or narrow therapeutic index have a much smaller safety margin.
Uh-oh.
Yeah, this significantly increases the risk of adverse effects or toxicity and often necessitates careful monitoring of blood drug levels. This includes measuring peak concentrations, the highest level after a dose, and trough concentrations, the lowest level right before the next dose.
The material also mentions the use of a loading dose. When might a healthcare provider decide to use one of those?
A loading dose is a higher initial dose of a drug given to rapidly achieve that critical concentration in the body. This strategy is often used for drugs that take a significant amount of time to reach therapeutic levels with regular maintenance dosing, especially when a rapid effect is needed.
Like in an emergency.
Exactly, or severe infections, acute cardiac conditions, things like that. Once the critical concentration is achieved with the loading dose, the drug is then continued at a lower maintenance dose to sustain that therapeutic level. Think of it like priming the pump to get things going quickly.
That makes sense. It's like jump-starting the system to get the drug working quickly in urgent situations.
Oh.
Now let's talk about half-life. This is a concept that always seems to come up in pharmacology discussions.
The half-life of a drug is the time it takes for the concentration of the drug in the body to decrease by 1/2 or 50% of its peak level. For example, if a drug has a half-life of 4 hours and you administer 100 milligrams,
Okay.
after 4 hours, only 50 milligrams will remain in the body. After another 4 hours, so 8 hours total, only 25 milligrams will be left, and so on. It decreases by half with each half-life period.
And why is knowing a drug's half-life so clinically important?
Because it's a key determinant of the appropriate dosing frequency and the duration of a drug's effects. Drugs with shorter half-lives are eliminated more quickly and often need to be given more frequently to maintain a therapeutic level.
More doses per day.
Right. Conversely, drugs with longer half-lives stay in the body longer, require less frequent dosing, but also carry a greater risk of drug accumulation and potential toxicity if not dosed appropriately, especially in people with impaired elimination, like poor kidney or liver function.
Accumulation risk.
Yes. The half-life of a drug is influenced by all those pharmacokinetic processes we talked about: absorption, distribution, metabolism, and excretion. Conditions like kidney or liver dysfunction can significantly prolong a drug's half-life because the body just can't clear the drug as efficiently.
So, understanding a drug's half-life is crucial for nurses in planning medication schedules and educating patients about their dosing regimen. Now, we've spent a good amount of time discussing pharmacodynamics and pharmacokinetics, but the material also delves into a wide array of other factors that can influence how a drug affects an individual. It's clearly not just about the properties of the drug itself.
That's a really critical point. The human body is incredibly complex, and numerous individual factors can significantly impact a person's response to medication. The material likely lists several of these. Body weight is an obvious one.
Right, wait.
Standard drug dosages are often based on an average adult weight, maybe like 70 kilograms. Individuals who are significantly heavier or lighter may need adjustments to get the desired effect without causing toxicity.
And age is another major factor, especially at the extremes of the lifespan you mentioned.
Absolutely. Infants, children, and older adults can process and respond to drugs very differently compared to the typical adult. Children have immature organ systems, particularly their liver and kidneys, which affects drug metabolism and elimination. They also have different body composition, things like gastric acidity, gastric emptying time, and their blood-brain barrier isn't fully developed early on.
So lots of differences in kids.
Lots. And older adults, on the other hand, often have multiple underlying health conditions and may be taking numerous medications concurrently. That's polypharmacy.
Polypharmacy, yes.
That significantly increases the risk of drug interactions. They also experience age-related physiological changes: decreased liver and kidney function, reduced GI motility, changes in body fat versus muscle. All of this can alter drug absorption, distribution, metabolism, and excretion. So a standard dose of a pain med might hit an older adult much harder or last much longer.
The material also touches on sex as a factor. Are there notable differences in how males and females might respond to certain medications?
There can be. For example, differences in body composition, proportion of muscle to fat, and variations in hormone levels can influence drug distribution and metabolism. Some drugs might distribute more readily in people with more body fat. And as we touched on briefly before, the material rightly emphasizes the critical importance of considering pregnancy status. Many drugs pose risks to a developing fetus.
Beyond these demographic factors, physiological aspects like our natural daily rhythms, our electrolyte and acid-base balance, and even our hydration status can play a role, can't they?
Yes, these internal states can definitely influence both how a drug exerts its effects and how the body processes it. For instance, some blood pressure meds might work better if taken at certain times of day, aligning with natural blood pressure rhythms. Imbalances in electrolytes like potassium or sodium can affect how certain heart medications work. And dehydration can impact drug concentration and kidney function, potentially altering drug excretion. It all interconnects.
And then there are pathological factors. The presence of other diseases or conditions in the body can certainly change how someone responds to a medication.
Precisely. Conditions affecting the GI system can mess with absorption of oral drugs. Cardiovascular diseases or low blood pressure can impact blood flow and therefore drug distribution. And, as we've already stressed, liver or kidney disease can dramatically affect metabolism and excretion, leading to drug accumulation and toxicity even with standard doses. Malnutrition, low protein levels, that can affect protein binding, changing how much free drug is available.
This is where the field of pharmacogenomics comes in, looking at how an individual's genetic makeup can influence their response to drugs.
This is a rapidly advancing and incredibly important area. Genetic variations can affect those CYP450 enzymes we talked about, leading to individuals being either rapid metabolizers or slow metabolizers of certain medications.
Fast or slow processors.
Exactly. This can have huge implications for drug effectiveness and side effect risk. The material might mention examples like certain antidepressants, where genetic testing can help predict which drug might work best, or specific genetic markers you have to screen for before giving certain meds to avoid severe reactions. It's a key part of personalized medicine tailoring treatment to the individual's genes.
We also need to consider the role of the immune system. Drug allergies are a significant concern in healthcare.
Absolutely. A person can develop an allergic or hypersensitivity reaction after being exposed to a drug previously and developing antibodies against it. Then, the next time they get that drug, it can trigger immune responses, from mild rashes to severe, life-threatening anaphylaxis.
Yeah, scary.
Very. It's crucial for nurses to always ask about and clearly document any known drug allergies.
It's fascinating how much our own mindset and beliefs can play a role, too. The placebo effect is a powerful example of that.
The placebo effect is real. A patient's expectation or belief in a drug's effectiveness can actually lead to measurable improvement. It's well documented. Additionally, a patient's overall attitude, their understanding of why they're taking the medication, and their ability and willingness to actually take it as prescribed adherence are all crucial for success.
Even seemingly minor environmental factors like the ambient temperature and noise levels can have an impact on drug effects, which is something we might not always readily consider.
That's right. For example, some blood pressure meds might be more effective in colder weather when blood pressure naturally tends to be higher. Or think about sedatives. A calm, quiet environment can definitely enhance their effects or improve response to pain relief.
And then we have the concepts of tolerance and accumulation, two more important considerations in long-term medication use.
Tolerance can develop over time with some drugs. The body just becomes less responsive, requiring higher doses for the same effect. Opioids are a classic example.
Right, tolerance with opioids.
And there's cross-tolerance, too, where tolerance to one drug in a class leads to reduced response to others in the same class. Accumulation happens when a drug is taken too often, or when the body can't metabolize or excrete it properly. It builds up, increasing the risk of side effects and toxicity.
Finally, we need to discuss the complexities of drug interactions, which can occur in many different ways. The material likely outlines several types of these interactions.
Drug interactions can occur when two or more drugs are taken together, or when drugs interact with other things like herbal supplements, food, or even mess with lab test results. These interactions can alter the pharmacokinetics or pharmacodynamics of one or both substances, potentially leading to decreased effectiveness or increased risk of adverse effects. Big area of concern.
Can you give us some practical examples of drug interactions that might occur at different stages of pharmacokinetics?
Certainly. At the absorption stage, one drug can affect how another is absorbed. For instance, taking tetracycline antibiotics with antacids containing calcium or magnesium can really reduce the antibiotic's absorption, making it less effective.
So don't take them together.
Right. During distribution, like we said, drugs can compete for protein binding sites. Aspirin can displace warfarin, increasing free warfarin and bleeding risk.
Finding competition.
In biotransformation, one drug can induce or inhibit liver enzymes metabolizing another. Phenytoin, an anticonvulsant, can induce enzymes that break down birth control pills, potentially making them less effective. Conversely, some antibiotics inhibit enzymes that break down warfarin, increasing warfarin levels and bleeding risk.
Metabolism interactions, got it.
During excretion, one drug can interfere with the kidney's excretion of another. Probenecid can block penicillin excretion sometimes. That's done on purpose to boost penicillin levels. And finally, drugs can interact at their site of action. Taking a blood pressure-lowering drug with a decongestant that raises blood pressure can counteract the intended effect.
And we certainly can't overlook drug-food interactions. Grapefruit juice seems to be a well-known example here.
Yes. Grapefruit juice is a big one. It contains compounds that significantly inhibit certain liver enzymes, those CYP enzymes, that metabolize many drugs. This inhibition can lead to much higher blood levels of those drugs, increasing side effect risk, and the effect can last for a day or two.
Wow, that long.
Yes. The material might also mention others, like MAOIs and tyramine-rich foods causing dangerous blood pressure spikes. Generally, unless told otherwise, taking oral meds with water on an empty stomach is best for absorption, but sometimes food is needed to reduce GI upset. You have to know the specific drug.
And finally, we should briefly touch on drug laboratory test interactions.
Right. These happen when a medication interferes with the test result itself, not necessarily causing a real physiological change. Like some diuretics might alter electrolyte readings on a lab test, or certain meds might interfere with blood glucose readings. Healthcare providers need to be aware of these potential interferences when interpreting lab results.
Wow, that's a truly comprehensive look at how medications interact with and move through the body and the multitude of factors that can influence their effects. It really underscores the complexity of pharmacology and the absolutely vital role nurses play in understanding these fundamental principles.
Absolutely. For nurses, understanding pharmacodynamics and pharmacokinetics isn't just theory. It's the foundation of safe, effective medication administration and patient care. By thoughtfully considering all these factors from the cellular level action to the patient's individual characteristics, nurses can anticipate problems, prevent adverse events, and provide truly individualized patient-centered care.
So for everyone listening, especially our future nurses, we really encourage you to think deeply about how these core concepts will apply to the specific medications you'll encounter. Consider the unique factors that might influence drug responses in your future patients. Maybe take a medication you're learning about and really delve into its pharmacokinetic and pharmacodynamic profiles, explore how these principles play out for that specific drug. It's a fascinating and absolutely crucial area of nursing, and a strong grasp of these basics will serve you incredibly well throughout your entire career. Thanks for taking this deep dive with us.